This conference will now be recorded.
All right. So you just see Hannah's face in the camera. Yeah, that one's yours. Merry Christmas. All right, a couple things we need to go over real quick. I've already hit record. The schedule for the ride-alongs is up here. If at this point, everybody should know if I couldn't fill you in on the days that you wanted, I reached out, contacted you, and kind of fill you in on some extra days. But that should be the final schedule. Everybody's on here. Take a picture of it. Remember what day you're supposed to be here. And like I said before, make sure you dress appropriately. You might have a day like Mr. Scarmazzino back here where you're playing in the snow on the interstate all day and you get nasty, dirty. Or Mr. Bell had to pick somebody up out of the mud and water last night. So dress appropriately. Understand that your clothes may get dirty. They may get ruined. Dress professionally, but dress with clothes that you're not scared to get dirty. Okay. I'm going to pass around a piece of paper tonight. And what we're going to do is we're going to order some shirts for the class for everybody whenever they graduate. They're not going to be anything super extravagant. They're going to be one of our Lander County EMS shirts. It'll have like class or EMT class 2501 on it. Just, something simple, something easy, just, a little memorial thing for the class. Just kind of, fun and whimsical. So I'll pass that out just so everybody can get their shirt sizes in, and I can go ahead and start. We can go ahead and start trying to order those. If you look at the schedule here, there's going to be some slight changes to the content over the next probably week and a half. So we have a couple of categories that's coming up, which is going to be cardiac emergency, resuscitation, and like neurological stuff. And those PowerPoints are huge. They are a lot of information. They are going to be a very long night if we don't condense some of this stuff down some. And so to try to make this as easy as possible, 17 and 18 will be tonight because they are shorter chapters. Instead of doing 18 on Thursday, we're going to do 19 on Thursday. And that way we can break up 20 and 21 into their own class days because, like I said, it's a lot of information. They are very big chapters, and pretty much the entirety of the class is going to be those PowerPoints by themselves. They're very in depth. And so instead of y'all having to sit here until 9 or 10 o'clock at night, we're going to try to break some of these up. This shouldn't affect your test very much. I guess the only major difference is when you come in Thursday, your pre-test for 18 is due on Wednesday, so we're going to go ahead and knock out 17 and 18 tests on Wednesday. They should be pretty simple. You've done your drug cards with the pharmacology stuff. It shouldn't be too much more information. With the pre-test due on Wednesday, we're going to go over the PowerPoint tonight. I'm going to go ahead and toss it on the test Thursday. So just be ready for that. And then 19 will be on its own test, 20 will be on its own test, and 21 will be on its own test, just because those chapters, especially 20 and 21, are a little bit more in depth. So, yep, that's my big things, right? So schedules are up here. I think Andrew is supposed to be here tomorrow, and then somebody from Austin is supposed to be here Friday. We pretty much have somebody scheduled every day for the next 2 months, almost every day. At this point, if you want extra ride time, I don't have a problem with it. I don't think anybody here would have a problem with it. If you're free on one of the days that are open and you just really want to come hang out, ride, whatever, I don't see an issue with it. So let me know. and we can try to pencil you in. Somebody asked me yesterday if they could ride extra. I don't have an issue with that, and I don't think anybody else does. So yeah, Saturdays. If you've signed up for a Saturday that we have class, basically what we're going to do is you're going to show up at 8 o'clock. Our start time is 8 a.m. You'll be here from 8 a.m. to 8 p.m. And you'll come into class just like you normally would. The only difference is if you get a call during that class period, you'll run that 911 call with us, because Saturdays are skills days. We're doing assessments and stuff, doing in-field assessments. Mr. Scaramazino will tell you firsthand, and I'm sure Jonathan Bell can attest to this. Doing assessments on real individuals that are having emergencies is a lot better than doing assessments on your friend that's sitting in a chair. So we're going to take you out with us on Saturdays if you're scheduled for that day. Tuesdays, if you're scheduled for those days, you'll have to sit in class just because that's PowerPoints, and I can't pull you out of class, miss PowerPoints for you to run the call. So be mindful of that. There was one more thing on the
charting.
Oh yeah, the charting. So what we're going to do, the PowerPoint that we're going over tonight is communications. We're going to touch on charting, how to chart. What we're going to do, and for the people that have already ridden, we're going to help them out and work through some of their charts. But what we're going to do is we're going to have y'all kind of write a narrative for your patient contacts. So if we run a 911 call, I'm not going to expect you to go into Imagetrend and build an entire chart, but we're going to sit you down and kind of write you a narrative, just so you get an idea of how these narratives need to be written. One of the biggest reasons why paramedics or EMTs get lawsuits and lose lawsuits is because of their charting. So if you chart bad, you lose money and possibly go to jail. I don't want that. Coming from the system that we come from, they were very, very big on the legalities of charting and how you charted. So that's a big thing for us, is how you chart, because I don't want you to get in trouble for charting something negligent or charting something inappropriate and then, not meaning to, but just put something in there that kind of screws you up in the long run. And then somebody comes back and, throws a big lawsuit at you and you get in trouble. So while you're with us, we're going to help you with your charting some. We're going to show you how to go through Imagetrend and run through some of those charts. It's a lot of information. A lot of it you don't really need. So we're just going to focus on the narrative with y'all. There's a couple of different formats for narrative. And do you touch on all the different formats on your PowerPoint, Hannah? Like the SOAP and all that stuff? So we're going to talk about the different formats. There's a couple of different ones. There's like a timeline format where you can just run through the whole call in a big timeline. National Registry like SOAP, which is like a certain format of charting. They really, really like it. So we're going to teach you that one. And that's kind of the one we're going to build your charts off of, or your narratives off of, is the SOAP format, just because National Registry likes to use that one.
I'll
so
go type up a template for it. I'm going to go type up a template for it real quick.
Oh, okay.
So we can have
all right. Cool. So I think that's all that I have. Saturday, work on your skill sheets, because we're gonna do a lot of that this weekend or this Saturday. And yeah, any questions? I think that's it. Maybe, I don't know. I'm sure I'm forgetting something. I'll remember it later on. So, yeah, that's gross. Yeah, that's gross. That's gross. All right. Well, if that's it, Miss Hannah, you're in charge. Oh, frick yeah. Y'all were supposed to take a test. You almost got me 2 times. 2 times. Sorry, I gotta find the password. Yeah, I gotta find it.
This conference will now be recorded. This conference will now be recorded.
Sorry. Tangled chairs here.
Ah.
Okay, is everybody ready? Okay, cool. So chapter 17, communication and documentation. So first we'll discuss the communication systems and radio communications. So communication systems, there's several different components. Can somebody tell me maybe a few components of the communication system that we would use here in EMS? Base station, mobile station, yeah. Portable, yeah. Repeaters, perfect, yeah. Yeah, yeah, yep. I think that covered all of them, actually. That was perfect. So first is the base station. It's set up with the two-way radios at a fixed site. So that's like your dispatch center or your hospital over here. Then we have mobile radios. So those are the radios that are actually affixed inside of our ambulances. And then portable radios, those are the handhelds that we all carry around on our hip. Repeaters. So repeaters pick up signals from lower powered units like the handheld radios and retransmits those signals at a higher power. So like when you're a further distance away, that signal will hit those repeaters to be able to come back to dispatch or whoever you're radioing. And then cell phones, we're kind of trying to go away from cell phones. That's something that we've run into here actually is we previously were calling in our patient reports to the hospital on our cell phones. But the thing about that is it's not a recorded line, and any kind of patient information we give needs to be, traceable, I guess. So cell phones, we're kind of getting away from that now, but communication between ourselves, obviously we can use cell phones for that. And then telemetry, so that's sending things like EKGs or vital signs, usually to the hospital from your truck. Radio communication, so just some principles of radio communication. We want to hold the push to talk button for 2 to 3 seconds before speaking. If you press it and immediately start talking, dispatch won't pick up the first part of what you said. So it just takes just a second for that mic to actually kick on. So wait 2 to 3 seconds before speaking. Hold the microphone 2 to 3 inches from your mouth. That's a big one. Some people love to eat the microphone, and it's just all really muffled and jumbled, and you can't hear what anybody's saying when you're that close, right? So just hold it a little bit away from your mouth. So this is kind of an important one. So when we're talking to people on the radio, we want to use the "Hey you, it's me" method. So if I'm trying to talk to dispatch and tell them, we're leaving scene and going to the hospital, I would say, "Hey dispatch." So "Hey you, hey dispatch, it's me." Okay, so for example, dispatch, rescue 1. So "Hey dispatch, I'm speaking, it's rescue 1, right? Is it? Right, yeah. Yeah, it's kind of, I don't know, hard to get the hang of that, but really? Who is you and who's me, right? Yeah. So we want to use plain English and try to avoid 10 codes. It just kind of depends on the service you're at, whether they use 10 codes, 10-4, 10-8, all those things or not. But using plain English is typically a little easier, so everybody in the system knows what you're talking about. Sometimes those 10 codes might be different in different service areas, so it's just a little easier just to use plain English when talking on the radio. So when transmitting a number, state the number and then repeat the individual digits. So if I'm saying, "Hey dispatch, I have a 15-year-old female, 5-year-old female," we want to say the number and then repeat those digits so that they can clearly interpret what we're saying. And then we want to protect patient privacy. So, we don't want to give any patient name, any of their personal information out over the radio. And then also no profanity. The FCC, I believe it is who is kind of over the radio comms. And that's prohibited. So no profanity, please. We want to speak slowly and clearly and make it short and sweet. So, hi. sometimes it's kind of hard, like we were talking about eating the mic, like it's hard to kind of decipher what you're saying sometimes. So speaking slow, enunciating your words, and make it short and sweet. We don't want to take up too much time on that airwave when other people might need to use that communication route as well. And then we want to notify dispatch of any updates. We want to let them know once we get dispatch. We want to let them know when we're en route to scene, when we arrive on scene, when we depart with the patient, or if we're not taking the patient, we might want to let them know, hey, patient refused, we're clearing from scene. Just keeping dispatch updated on what we're doing throughout that call. So then we have radio medical report. So this is like the report we would give when we're en route to the hospital with a patient on board. So we want to paint a picture. Again, we want to keep it short and sweet and give them pertinent information only. Because once we get to the hospital, we can give them more of an in-depth report with all of their allergies and the medications and all the things. But on the radio, we just want to give them the information that they need to know right now. So again, we want to use that, hey you, hey BMGH, it's Rescue 1. Hey you, it's me. We want to let them know our ETA. We're about 15 minutes out. We want to give them the age, sex, chief complaint, nature of illness, injuries, mechanism of injury, basically just an overview of the kind of patient that we have. And I'll give you a kind of an example report after we go through these points. Once you give them kind of the rundown on your patient, we want to ask them, do you have any further questions for me or any orders from medical direction? Anything else they need to say to us before we get back to what we were doing? Uh-oh, have a typo. But anyways, then this goes back to our verbal report. So once we get to the hospital, we're going to give them another report, which is the verbal report. And that just kind of expounds on everything we told them over the radio, right? So let's say I have a 65-year-old male patient that has chief complaint of, let's say chest pain, right? Okay. So this is like a example radio report you might give. BMGH, this is Rescue 1. We're 15 minutes out with a 65-year-old male patient with a chief complaint of chest pain. This started about 10 minutes ago. He's never had a history of this. His current vital signs are heart rate, blah, 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 blood pressure, SpO2. We've given him nitro. We've given him 324 of aspirin. We've started an IV in the left AC. Do you have any further questions or orders? So just really short and simple. Not a whole lot of extra information, just basically exactly what they need to know so they know where to place that patient when we get there. Were there any questions on giving a report over the radio or in person, any of that? No? Cool. Okay. Interpersonal communication. I don't really think it mentions this in your book, but I thought I would bring it up, talking about closed loop communication. Does anybody know what that is? Repeating back, exactly. So let's say we're on scene and my paramedic tells me to give Benadryl. What's your dose for Benadryl? Can you guys give Benadryl? No? Okay, let's not do that then. Let's do, you can give aspirin, right? Okay, what's your dose for aspirin? Okay, let's say I'm a paramedic and I tell you give 324 milligrams of aspirin. You would want to come back to me and say, copy that, I'm going to give 324 milligrams of aspirin. Just that's that closed loop there. So I'm telling you to do something, you're repeating back to me so that I know you understood exactly what I said, right? And we didn't get the dosage wrong in between there. So there's the example. I'll tell you, hey, give 1 milliliter of epinephrine. Then you'd repeat back to me, I'm going to give 1 ml of epinephrine. And then when you give it, tell me you gave it, right? So then when it comes to communicating with our patients, we want to use therapeutic communication. So we want to use eye contact that shows them we're listening, right? Be aware of our position and our body language. So probably the way I'm standing right now wouldn't be super great to talk to a patient, like my hands in my pocket, just super like, don't really care what you're saying to me kind of stance, right? Like we want to look like we're engaged with our patients. We want to not cross our arms. That can be kind of closed off, right? Just kind of watching the way we're presenting ourselves so that patient feels comfortable talking to us. We want to use patient language that the patient can understand. So we don't maybe want to use all the medical terminology that we know. We might want to use high blood pressure rather than hypertension, things like that. We want to be honest with the patient. We might not always have answers for them, right? Like there's a lot of times patients will ask me things and I just have to say, you know, honestly, I don't have an answer for you right now, but, you know, we'll figure it out, or, you know, I don't know what's going to happen, but we're going to work through it together, or whatever, you know. Just don't lie to a patient, because they'll catch that really quickly and that can cause more problems. We want to use the patient's proper name. I don't know if it's so much of a problem here, but I'm from North Carolina, and so over there we're calling everybody honey, sweetheart, and oh, that's okay, babe, you know, we're, you know, whatever. Just using those nicknames like that is not super appropriate when we're dealing with patients. So just always use their proper name or whatever they prefer. And then listen to them. That's a big part, you know, like they might ramble on for a while, but listening and trying to pick up clues about what might be going on from what they're saying is important. Okay, so the pre-hospital care report, which is also known as the PCR. So functions of the PCR, can anybody tell me what is a PCR for? Okay, what else? For trends, sure, yeah. Okay, what about like legal reasons, right? It can be pulled to be used in court, right? So number one, it's a patient care record. This becomes part of the patient's permanent health care record. So anything you put in there should be accurate and complete, because this is part of their record. It's also a legal document. This is a big one. If you just kind of run through your PCR and you don't really put a lot of effort in, that might come back to bite you in the butt. If you get called into court, these PCRs are things that you can look at to recall kind of what happened on your call. And then the more detail you put in that, the more you have to go on, right? Like sometimes these court cases don't happen for 2 or 3 years after the call. So, you know, 2 or 3 years from now, are you going to remember what your patient said 3 years ago? Probably not. So it's important to add all that detail so that you do remember. They're also used as administrative data. So insurance and billing information is typically obtained from PCRs. They can be used for education and research. They can show trends, like we said in the back. And then it can be used to analyze your own performance as well. So, you know, how many IVs did I get this year? You can kind of use those PCRs sometimes to look at that. Another one actually would be, like it says here, to be used for case studies. So sometimes a service will do like a monthly review or a monthly case study where they'll pull a case that we've had in the past month and kind of just go over what happened and how we can learn from it and things we could have done better. And then we have quality improvement. So that's reviewing the PCR for adherence to current medical and organizational standards. So QI, your charts get QI'd just to make sure, you know, you're performing the correct procedures and doing them the correct way. It's important to complete your PCR as soon as possible or within 24 hours of the call. The longer you go after the call without doing your report, the more you're going to forget. If you can get that PCR done as soon as you finish your call, you're going to recollect more of what actually happened, what the patient said, what they looked like, things like that. So elements of the PCR, what do we think goes into a patient care report? Vitals, perfect. What else? Chief complaint. How about the patient's name, their birthday, their information, what we did, our interventions, right? So legally, PCRs have to have certain data elements. There's a minimum data set, and that includes run data and patient information. So what is run data? Time we responded, right? Different things like what rig we ran out of, rescue 1 or rescue 4, what time, what date. Dang, another typo. Sorry, geez. Okay, run data is our dates, times, run numbers, unit, the personnel that were on the call, and then other basic information. Patient information includes their name, address, sex, age, date of birth, and then billing and insurance info. We want to include information that we gathered during the call, so our general impression of our patient. We're going to have a narrative, vitals, exam findings, and transport info, whether we transported them or not, if they refused. So the big part of a PCR is your narrative, and some people have a hard time with narratives, but really it's just writing exactly what happened from the moment you got on scene until you drop your patient off or until you leave your patient, right? Your narrative should paint a picture from the time you arrive to when you leave. Be very descriptive. Like we talked about court before, if you get called into court, you can go back and read these narratives. So the more information and the more descriptive you are, the more you have to go off of when you're reading these things later. So we want to include your own observations. That's the objective information. And then we also want to include patient statements. So that's the subjective information. So for example, objective would be the patient had a 104 Fahrenheit fever. That's something that we directly observed. We know that's a fact. And then the patient states, I feel dizzy. That's subjective. That's what the patient feels. It's what he tells you. It's not something that we can actually directly observe other than him just telling us, right? We want to include pertinent negatives. So pertinent negatives are things that aren't happening with your patient. So a lot of times when a patient has chest pain, they may also have shortness of breath. If your patient doesn't, you want to add that in. The patient complains of chest pain, but reports no difficulty breathing. That kind of, just kind of narrows down what's going on with your patient. We want to avoid non-standard abbreviations and use correct spelling. That's important. And then if we are going to use medical terminology, we want to use it correctly. So don't just put big words in if you don't know what they mean, right? So if it isn't written in your PCR, you didn't do it. So anything that you do to a patient, any intervention you perform, you have to put it in your PCR. CJ just came in and he's like, on one of your charts, you put that you took a temperature, but didn't put the temperature. And I'm like, oh shit. So sometimes you have to come up with a way to organize these things in your head. It might be hard to keep track of all of your vitals and all of your interventions and things. So whether you write that on your glove or chart it immediately while you're on the call or whatever works for you, whatever system works, write all these things down so that you're making sure it goes in the PCR. Okay, special documentation issues. Legal issues. So confidentiality, we all know about HIPAA, right? Patient privacy. Patient refusals. So refusals can turn into problems if our patient declines or dies after we leave, right? So when a patient wants to refuse, we have to make sure that they're informed that we're not going to be liable for that, right? Like it sounds kind of harsh, but we want to try to persuade our patients to go to the hospital. Like if it looks like there's something that could even remotely be wrong with them, we want to try to get them to go because there's a reason they called 911, right? The patient must be ANO ×4 to refuse. If they have an altered mental status, they cannot refuse transport, okay? We want to inform the patient of potential consequences of refusal up to and including death. So a lot of times what I'll say is, the patient tells me, I think I'm okay, I don't really want to go. So what I'll say in response to that is, okay, that's fine. I can't force you to go to the hospital, but you do have to know that there are a lot of things that could be going on with you that I can't necessarily assess in the field. It would take more definitive care and testing to find out what's really going on. If it's a trauma, there might be internal injuries that I can't see here in the field that could lead to death. So, I can't make you go, but I would strongly advise it, try to persuade them, all those things. Another legal issue is falsification. So there's two different types of falsification. There's omission, so leaving things out that we did do. So if I started an IV, it needs to be in the chart. If I leave that out, that's falsification, and it's omission. And then commission, that's actions performed on the patient that were wrong or improper. So let's say, I don't know, you have a patient with chest pain and you give them something improper, right? Like you give them something out of your scope or you do something incorrectly. That's an act of commission, and that's also falsification. Correction of errors. So these days we don't usually use paper PCRs like ever anywhere. But if you ever do, or if you ever have to correct something on paper, we just want to draw one line through the incorrect portion of that PCR and then put your initials beside it. Okay, special situations. Multiple casualty incidents, MCIs. So documentation for MCIs is a little more difficult because you might have multiple patients, right? There could be 10 or there could be 50 people that you're running through, and it's kind of impossible to write about, you know, all those patients individually. But we also use triage tagging during MCIs. Do we know what triage tagging is? No? Somebody say no? Yeah? Okay. So triage tags are these little sheets of paper, rectangular sheets of paper, and they have green, yellow, red, and black on them. I think she's going to go grab them right now. When we have an MCI with a ton of people, we can't assess them all as in depth as we would like to, maybe. And when there's that many people, we need to try to help as many as possible. So we use these tags to kind of label how severe a patient might be, right? So if I go up to someone laying on the ground and I see that they're dead, they're a black label because they're dead, right? I label him as black and we move on. That way we know later when we come back to him, okay, he's dead. Like we don't have to mess with that, right? There's some other criteria that go into it. I can't tell it all to you off the top of my head, to be honest with you, but there's other things that would classify you as red, yellow, or green. Green is you are able to stand up and walk away from the scene on your own. Like you're good. You know, you might have a scrape or something here or there, but for the most part, you're good. We'll look at them when Rebecca brings it back in. And then there's also special situation reports. So like if you're exposed to an infectious disease or have a needle stick that, you know, that's unsanitary, you can do a report for that. Injury to yourself might warrant a report. Mandatory reports for child or elder abuse, excuse me. Yeah, that's all I've got. Does anybody have questions on any of that? No? These are our triage tags. That's what they look like. So yeah, black is deceased, red is they need immediate help. Yellow is they can be delayed, like they've got some things going on, but we can kind of delay that for a little while. And green is minor injury, so they can stand up and walk away from the scene on their own. Yeah, so I'll just pass this around so you guys can, oh, okay, cool. Do you want to pass that one back? One's coming down your row, so. Cool. Any questions online? Is everybody good there? Okay.
Y'all can take 5 minutes if you want to use the bathroom or smoke break. You already got your PowerPoint pulled
up? Maybe. Hold on. You worked too hard to lose that one. Rude? Yeah. Put on and I'll see. Oh, it's right here.
All right. So, any other questions about the charting stuff? Yeah, we're kind of running ahead of schedule. So, just remember, like I was saying, charting is a huge, huge part of what you're going to do, just because a lot of our legal issues come back to charts. And so, actually, what they did in paramedic school for Becca was they would bring you in and they would sit you down and they would drill you just like you were in a courtroom. And so they would go over your chart, they'd look at your chart, and you'd have to sit there and explain your chart to somebody else. And most people lost. And it can cost you a lot of money, a lot of legal issues. So at some point, probably Saturday, since everybody will be here Saturday, we have a test chart that we built to teach a charting class for everybody that works here. And we'll try to get that pulled up for everybody. We'll run you through what it looks like. We'll run you through what our chart looks like. It is a call that me and Becca ran. So it is all, it's all very, very factual information. We just left some of the HIPAA violation stuff out of it so that we don't get in trouble. But I mean, even if it's, a simple refusals or a huge one, if you get refusals on patients and you aren't articulating that they are within their mental capacity to refuse transport, and you get a refusal on them and something happens, and the family comes back and tries to sue you, then it is a very, very bad situation that you don't want to be involved in. So take the charting stuff seriously. It's aggravating, it's time consuming, and it's monotonous, but it's very important to make sure that you do it appropriately.
My best advice to you is, as you're writing the chart, write what you want your future self to thank you for, because whenever these court cases happen, it's not like it's happening next week. It's like years from now. So then being like, this one patient that you ran 2 years ago, and you're not going to recall anything. So putting the information in there is important.
And put it in there like it makes sense to you.
Yeah.
Because you're not writing your chart for anybody other than yourself. Other people are going to pull your chart, but if you go in front of a court, you need to know what that chart says. And so write the chart to where it makes sense to you. And like she said, if you come into a court case, you don't want to write a chart that you don't understand, and then you get pulled into a court case 3 or 4 years from now, and then they're like, "Hey, explain this chart to us," and you're like, "Frick, I don't know I don't know what's happening," because it just doesn't end well.
My biggest pet peeve is you'll see some charting systems where they have like auto-generated narratives. Please don't ever use those. Good Lord.
Yeah,
they drive me nuts. They just
terrible.
pull everything that you already inputted in the chart and put it in the narrative, so you get no subjective information. So it's like EMS arrived at this time, found the patient, and these were the vitals.
Found patient complaint, chest pain. Vitals, this. Patient loaded, stretcher. Patient moved, ambulance. Like it's so bad. Just bad. Don't ever do that.
Yeah. All right. So pharmacology. This is kind of just a general overview, because as it goes into your books, like as they go into the different types of medications, like the route, the dose, all that stuff is actually in the chapter correlated with that medication. I added a couple extra things in here. You guys should know these pretty well because we just did med cards that y'all got back. So I would recommend studying those, learning your doses, learning your indications, learning what they do, because if you don't know what a medication, how it works, you should not be giving it, right? So here's these should look familiar. Practice putting on a nasal cannula, because the first time I put one on, I tied it behind the person's head and I look like a ding ding. So we'll practice in class. So whenever you're actually doing it on a real patient, it's put on correctly. But yeah, you guys, this should all look familiar to y'all.
If you come ride with us, Mr. Bell will tell you, because he rode with me and Becca yesterday for a handful of hours. If you come ride with us, we will drill you on these medications. Because like she said, if you don't know the medication, what it does, then you're not going to be given a medication because that's not appropriate, right?
Yeah. So one thing that I did want to point out is some of these look different. So, you know, these, we carry these ones, but some places carry this. Some people carry this. Ours looks a little bit different. You'll see that whenever you start doing ride time on the truck. EpiPens, they all can look different as well. So just getting a general idea of how they work. Most of them work the same. You might see this, you might see it on their little necklace. It might not even look like this. So just understanding that not everything's going to look the same is kind of a big deal. So information about medications. So we have the drug name, right? So we have a generic name, and then we have the chemical name, and then we have the brand name. So
thanks for
what we refer, are you leaving? See you later. Thank you. So what we refer to, like aspirin, somebody might call Bear, because that's this name, Bear. We have a lot of different things like that on the ambulance, like naloxone, Narcan. Whenever you grab our Narcan vials, it says naloxone on there. So kind of knowing what the generic name is important.
Some of the EPIs that you see say epi, and some of them say adrenaline on them.
Yeah. So they're gonna, there's a possibility that they say different names. So knowing both of those names is important. With the chemical names, not as important. But knowing like, hey, acetylsalic acid is aspirin, it kind of helps you eventually, right? So whenever you are giving a medication, there's things that you need to know, right? So you need to know the indications. What is an indication? Why you're giving it to them, right? So chest pain patients, that's an indication for nitro and for aspirin, right? What's a contraindication? Exactly. So why you can't give it. So like an example for aspirin, you can't give aspirin if they have active GI bleeding, right? Why is that? It's going to make them bleed more, right? Side effects, what's a side effect? Yeah, so things that are going to hurt them that's not associated in fixing them, right? So you can also have untoward effects. So does anybody know what an untoward effect is? So that's an effect that you're most likely going to get from that medication. It doesn't really harm them, but it's kind of telling you that the medication is working. So like nitro, you can get a headache, right? But then you can get an untoward effect. That's telling you that that nitro is doing what it's supposed to do. Like you're going to get this side effect, but that means the medication is doing what it's supposed to do. So we have different forms of medication. Nitro can be a pill, or it can be a little fluid like this. If you're talking about like suspensions, your activated charcoal is a suspension. So you have to mix that up because it'll separate. You get like the little solids and the liquids. You got to mix it up. Gels, you'll see gels, not so much. I mean, the oral glucose is considered a gel, I guess. We have fine powder, which I don't think we carry anything in a fine powder. Gases, what's one big gas that y'all can give? Oxygen, right? Oxygen is a medication. What is sublingual? Under the tongue, yeah. So lingua, lingual. You guys have your handout goes through all this stuff. The ones that are most confusing is PO, because what does PO stand for? Oral, by mouth. I don't know how they get a P and an O in there. It's kind of like the whole ventilation perfusion, the VQ mismatch. Where the Q comes from, nobody knows, but that's what it is. Another one that can be kind of confusing is subcutaneous. They put a Q. That one makes more sense. Subcutaneous. It sounds like a Q. So knowing the abbreviations for this if you use this like in your charting, these are like generic terms, right? So like if you say I administered aspirin PO, most everybody's going to know what that means. Don't just make up your own abbreviations like BM. That does not mean by mouth in the medical field, right? It means bowel movement. So if you memorize these, kind of makes your charting a little bit easier, a little bit simpler. So whenever we're talking about pharmacodynamics, it's how those medications are affecting how they work on the body, right? So whenever we're giving a medication, this is important to know, and it gives you a general idea, because why do we give aspirin for chest pain? Does anybody know? What? Yeah. It's an antiplatelet, so it's going to make your blood less sticky. Why is that important for chest pain patients? Yeah, so if there's a clot or something going on in their heart, it's actually going to allow more blood past that little clot. So some people think, oh, I'm giving aspirin because it's pain and aspirin's a painkiller, but that's not why we're giving aspirin. So these things are important to know on why you're giving medications, right? What effect will this medication have on the body, and how will it affect my patient specifically? So come back to like the nitro thing, we give it for chest pain because it helps dilate those vessels. We're trying to perfuse that heart. There are certain patient specifications that change. So like whenever you look at like our older population, metabolism slows down. Children metabolisms are very fast. So different patients kind of metabolize these medications a little bit differently. So agonist versus antagonist. So whenever we're talking about the mechanism of action of a drug, we're talking, a lot of times you'll hear these two terms. So agonist creates a certain action. So like albuterol would be a beta-2 agonist. It affects those beta-2 receptors. And an antagonist opposes that action. So a big one here is like Narcan. It's an antagonist of the opioid receptors because it's taking over those opioid receptors in place of whatever drug they took before, like fentanyl or whatever. Here's a little picture. I don't know if you guys can see it very well. Agonist is happy and they're friends. Antagonist is like F you. So 5 rights, these are important to know before you give a medication to anybody.
It's also important to know for your national registry because they will ask you questions on stuff like this.
Yeah. There's actually 10 rights. They only teach y'all 5, but there's 10 of them. But these are the most important ones, right? So do I have the right patient? Obviously, this is a little easier in the pre-hospital setting because normally you only have one patient. If you ever get a job as like an ER tech or something, that's where that really comes into play. Like, hey, I'm pulling this drug. I was told to give this drug to room 5. Am I actually giving it to room 5? Is the right person in there? That's important. The right time. So the timing of the medication. As an EMT basic, our medications are pretty generalized. You don't have like a specific order that you're giving them. But that also is important to note, right? Is it the right medication? That's a big one. And that kind of comes back to knowing like the brand names and the generic names. Because if I pull up Toradol and I'm like, oh, it's Toradol, and I read it and I'm like, oh, actually that's Narcan, like that's a medication error, right? So I want to double check with my partner, whoever I'm on the truck with, if they're the same level as me, that I am giving the right medication. And everybody should be doing that. Like, hey, this is Narcan. Is this Narcan? Yes, it's Narcan. Another thing that we want to look at is the right dose. So if you're giving the wrong dose, obviously that can be a problem. Either it's going to do harm because you're giving too much of it, or it's not going to do anything because you're not giving enough. So that's important to know. And then the right route. So if I'm going to be crushing up aspirin and sticking it in someone's IV, I'm going to cause them harm, right? So we're going to make sure that we're giving it the direct or the right way.
And children's Tylenol does not go in an IV.
Yes, please. Don't do that.
There was a fire department in Georgia that did that. They got in a lot of trouble. If it's red and it's on an ambulance, just be careful before you stick it in an IV.
Yeah. So whenever we give medications on an ambulance, we have a different ways that we can get permission to give these medications. So we have offline medical direction. This is our standing order. So whenever you open your protocol book, those are our protocols. It says, hey, you are authorized to give aspirin 324 milligrams by mouth. These are going to change from agency to agency. So whenever we teach you EMT stuff, you guys have like a broad
Scope of
practice. But some places that you work might be like, hey, you can't do CPAP, whereas you can as like an EMT. So this is our standing orders in the protocol book. And then our online medical directions. So sometimes you might have to call a doctor, your medical direction, or the hospital that you're associated with, and speak with a doctor and get orders to give a medication. So whenever they give you that order, kind of that closed loop communication that we were talking about with Hannah. So if I was calling and Chaz was the medical direction, I'd say, ring, ring.
Hello?
Is this Dr. So-and-so?
No, this is paramedic Chaz.
Okay, perfect. Paramedic Chaz. You're a doctor today. So I have a patient here with difficulty breathing. I need some medical direction on what to give next. What am I going to give?
I would start out with some albuterol. That'd be a good place to start.
How about a dose for that albuterol?
Well, you can start out with 2.5 or 5, whatever your albuterol is packaged in.
Perfect. So I'm going to give 2.5 to 5 of albuterol. Is that correct?
Yes.
All right,
Yes.
perfect. So if I need clarification on anything, I'm going to ask them. It's going to be a closed loop communication. I'm going to repeat it back to them, because if someone tells me to give 25 milligrams of albuterol, I might be like, hey, that's not right. So I'm just going to confirm with them that that's actually what they want. And then don't be afraid to be like, hey, that seems like a lot. I'm used to this dose. Could you clarify? And then they can sometimes fix it. Anytime you give a medication, we're going to reassess the patient. We're going to reassess vitals. We're going to reassess the system that we're treating. So if there's a difficulty breathing patient and I give albuterol, I listen to lung sounds before I give albuterol and I listen to them after, right? And then I'm going to document any changes that happen after that medication is administered. So let's talk about oral glucose. What is hypoglycemia? Okay, what's my normal blood sugar?
From what the book says, or from what it actually says?
From what the book
What
says.
the book says. Yeah, I'll read the book.
What are y'all's, like 80, 70 to 120, or?
I think it's 60 to 100.
Yeah,
Yeah. So usually about 60 to 130 is kind of what you'll hear here and there. I think your book says 60 to 100.
Yeah, we got
Yeah.
one that lives across the street that regularly sits at like 250. That's fine.
Right. So hypoglycemia, right? Usually signs and symptoms associated with hypoglycemia: altered mental status, cool and clammy skin. So remember, cool and clammy, need some candy. Contraindications of oral glucose. Please, on any medication, do not stick things in unconscious people's mouths. Okay. That is like a broad, that's just in every aspect of medicine. Seizure, people are like, stick a sock in their mouth. Please don't. Don't stick your fingers in their mouth, those kinds of things. So they need to be able to follow commands. If they're too altered to follow commands, don't go shoving gel in their mouth, because why? Yeah, you don't want to choke on it and aspirate, right? What's your dose for oral glucose?
Dun, dun, dun. Huh?
0.5 is not 0.5.
No. It is
15. 10 to 15. So usually it's one tube
tube.
or a half a tube. Usually, if I'm going to be completely honest with y'all, if I'm in a situation where someone's hypoglycemic and they're alert enough for me to give them oral glucose and I'm in their house, I'm just going to go get them some orange juice or some juice or something to eat. Because if they're alert enough to eat oral glucose, they're alert enough to like drink some juice, right? This stuff tastes gross. So if you can kind of avoid it, it's a little bit better. But
most of the time, if they're following commands, just hand it to them and tell them to suck on it. Don't sit over there and like baby feed them. Just give it to them.
yeah,
They can do it on their own.
yeah. All right. Narcan, right? So it's called Narcan, not Narcant.
Yes.
We love Narcan. This is what we carry on our ambulance. So whenever we're talking about like the different, how you'll see it, this is what it looks like. This part with the red cap screws into the back of the yellow part. This white thing is called a nasal atomizer, and we screw that on the end, and whenever you squirt it, it'll mist it, right? So things to remember about Narcan: if you have control over how much you're pushing, which those preloaded ones usually don't, try to do half the dose in one nostril and half the dose in the other, because you really only want to give like 0.5 mils of fluid per nair. You don't want to drown them out. They do not have to be breathing for this to take effect. If you put it in their nose, it's absorbed by their mucous membranes. So remember that. Usually whenever I put it in their nose and give it to them, I put it in their nostril and I angle it towards the top of their opposite ear. So you're getting it against all of that mucous membrane. So antagonist, what is this telling you? It blocks receptors, good. And what is your dose? Yeah, 0.4 to 4. So if you titrate it, try to titrate it to effect. If you sometimes those ones that you get pre-filled, you just give all 4 at once and you can't really control how much you're giving. But yeah, 0.4 to 4.
What's our big takeaway from Narcan? What do you have to do before you give Narcan?
Yes.
Okay, I like
Yes,
it. Don't wake these folks up with oxygen saturation of 50% because they will beat the dog piss out of you.
Yeah,
I promise
they
you.
will. It's true. All right, nitroglycerin. So another name for this would be nitro. It's a nitrate. So what it does is it vasodilates. What is vasodilation? Makes your vessels bigger. Okay. So you guys cannot just give this. It has to be prescribed to the patient. So they have to have their own nitro, and then you're assisting them with their doses. Okay. Per national registry, you can give up to 3 doses, and you have to call medical control for the 3rd one. What is one big thing that we want to look out for before giving nitro? Viagra, blood pressure, and heart rate. So blood pressure is the big one. In most protocols and in your book, they go off of systolic blood pressure, being if it's less than 100, you don't want to give it because it's going to cause it to dump even further down. There's actually a lot of stuff coming out now where it's actually the diastolic being less than 60, you don't want to give it. So I did put that in your guys' medication information sheet. So if you see that and you're wondering why, it has to do with because what you're doing is you're taking away that preload, right? So how much fluid that heart's getting upon initial pump. And then whenever you take that away from the patient, that's what's causing their blood pressure to go down. Side effects, hypotension, headache. Like we talked about, the headache, that's kind of an untoward effect as well because it's telling us that nitroglycerin is working. Whenever you give it, make sure you're documenting hey, your pain was a 10 out of 10 before, what is it now? So these are things to keep in mind with nitro. All right, so bronchodilators. This is like your albuterol. This is also another one where you guys, per national registry, can't just give it. It has to be prescribed to the patient. They have their little inhaler. This is what it looks like on our ambulance. These little plastic things, I call them fish. That's just what I learned. I don't know why we call them fish, but that's what they are. So your dose is 1 pump, right? Every 5 minutes, correct? So what kind of lung sounds are you going to hear before you give albuterol usually? Wheezing. Yeah. What does wheezing tell you that's going on in their lungs? Bronchoconstriction. Yes. All right. Side effects. This drug, albuterol, is a sympathomimetic. So what that means is it mimics your sympathetic nervous nervous system. So think about what happens when our sympathetic nervous system is engaged. What happens to our heart rate? It increases. What happens to our blood pressure? It goes up. And then what else happens? We kind of get shaky and anxious, right? So because this is mimicking the sympathetic nervous system, you're going to have those side effects of sympathetic stimulation, right? Same thing with epi, sympathomimetic, so it kind of heightens everything up, right? So epi, the auto-injector, this also has to be prescribed to the patient, or it has to be pre-drawn for you. I believe in the state of Nevada, it has to be prescribed to the patient, right? I will confirm that and get back to y'all. I think there was kind of a thing. In Georgia, we could pre-draw the epi for our EMT basics, and they could give it. So I'll clarify that for the state of Nevada. It's kind of different wherever you go. That's where it goes back to reading your protocols, right? So vasoconstrictor, what does that mean? Constricts the vessels. Bronchodilator, opens up the bronchioles in the airway, right? So side effects, a lot of the same stuff as your albuterol because it's a sympathomimetic. So one big takeaway from epi, I don't know if you guys still have the picture of it. Let me go back to the picture. The most common epi auto-injector, yeah, it's like the little blue and orange EpiPen. Wow. No, we just pull it up. Like it comes in a little vial and we just pull up 0.3. So your dosing so these two are different. So this one's EpiPen Junior, the green one on the bottom. That's a kid's EpiPen. So that has 0.15 milligrams of epi in it. And then the yellow one is the adult one that has 0.3 in it. So blue to the sky, orange to the guy. The problem is whenever people go to give it and they give it upside down, they inject their thumb. That sucks. It's never happened to me, but I've seen it happen. It sucks. Whenever you're giving epi, try to use big muscle groups because we want that blood flow from the big muscle groups. It's going to get in their system quicker. So I prefer like lateral thigh in the butt, but you got to be careful about the butt because we have a nerve that runs down our butt cheek. So if you hit that, it's really going to hurt. So sideways here, sideways here. You can do the arm. Okay, you can go through clothing, most clothing. There's some thick clothing out there, so use your judgment.
Scenario time. You get paged out to a 14-year-old who is having difficulty breathing post eating peanuts. You get on scene. She's audibly wheezing. Her heart rate's 160. Are you going to give her epi? So one big thing to take away from that is what's one of the big side effects to epi? Yep. Mm-hmm. But her heart rate's 160, but why? So that's what you have to consider whenever you give these medications, right? If you fix the problem, do you fix the heart rate issue? Her heart rate's 160 and you give her epi. Are you going to fix that issue because you're fixing her allergic reaction issue? Yes. So I ran a call on a 14-year-old, severe anaphylaxis. I gave her 3 rounds of epi. The first round of epi that I did, I walked in, I stuck a pulse ox on her finger. Her heart rate was 160 and she was sat in about 88, 89%. The first thing I did was stab her in the arm with epi. Within 5 minutes, her heart rate was back down to like 120, right? Still not beautiful. I ended up having to dose her 3 times with epinephrine. But don't get scared just because their heart rate's really high that you're going to drive their heart rate higher because you're giving it to fix an issue. And fixing that issue is probably going to drive her heart rate down. And so that's what you're trying to accomplish. So keep that in mind while you're giving these medications.
Yeah. And like Amanda said, just to reiterate,
there's no contraindications for epi and anaphylaxis. So
Yeah.
if they're in anaphylaxis, don't hesitate to give the epi. That is what's going to save their life. We can give Benadryl and all this other crap later, but that epi is first line treatment. All right, so force protection medications. These are medications that are usually put on the ambulance for your sake. The biggest one that we see is the duodote. So this has atropine in it and pralidoxome, I believe. So what this is used for is like organophosphate exposure. So you get real leaky. Basically, you start crying, you start puking, you have diarrhea. So this is for you. This is not for the patient. So yeah, and it looks like an epi injector, you just in your own leg, if you can bring yourself to do that.
I couldn't do it.
Yeah. So some common medications that you might see that is prescribed to the patient, you're not going to be able to give this stuff. But it's really good to know this, because if your patient is unconscious, unresponsive, and you can't get a good history, or if your patient is just a really poor historian and you have a list of medications that they take every single day, these are good things to know. So Advair is one that is usually given to like chronic breathing patients, breathing problem patients. So it's a steroid. It's an inhaled steroid. There are some herbal agents. I'm not going to say you guys have to memorize all these. I don't know what most of these things do. We're going to make sure that this is not going to be on your test, because this is too much. But just keep in mind that people can take a lot of herbal stuff, and sometimes those do affect the medications that they are taking, like that are prescribed to them. So, yeah. I'm trying to think of which one of these I probably see the most common.
Probably ginger root.
Ginger's common. Yeah. St. John's wort, I see a lot for like the people take it. So yeah. So these are some commonly prescribed medications for hypertension. So you have your lisinopril, which is an ACE inhibitor, losartan, amlodipine, furosemide, which is just a fancy word for Lasix, and then everyone's favorite, HCTZ, which is hydrochlorothiazide. Normally you'll just see it as this, and sometimes it's mixed in with other medications. Common medications for cholesterol. So this is high like blood lipids. So a lot of fat in their blood. So atorvastatin is probably the most common one, either atorvastatin or Lipitor. Any medications ending in statin, like atorvastatin, that kind of clues you in that it's a cholesterol medication. So somebody with high cholesterol might be kind of predisposed to what kind of conditions? Heart attacks, stroke, heart failure, those kinds of things. Diabetes, so we have metformin, which is most commonly prescribed for like your type 2 diabetics. So usually they're not on insulin. And then obviously we have our insulin. There's different types of insulin. There's long-acting and short-acting insulin. And then semaglutides really come in now. This is like a common medication that's being prescribed. Everyone's heard of the little shots that everyone's getting.
Oh, weight loss shot.
The weight loss shot, yeah, that's a really
Everybody's taking
for
it.
diabetes, yeah.
It's terrible for you. Don't do it. Just freaking eat like a decent human, and then you can lose some weight.
Yeah. So this is the last little bit of this. They have it in your book. I'm actually just gonna go grab a drip set and a med bag real quick so I can show you how to do this, and I'll be right back.
Freaking trizepatide.
Hello. Yes.
Is
I'm just
can one of y'all down in Austin key up? Is Mike still down there with y'all? Mike and or Kim? I don't know if they can hear me. I know they can hear me. I just don't know if we can hear them. It's two different issues. Kim is there. Kim, Matt, if you will ask Kim to show y'all how to set up a drip set, that's what we're about to do up here. It's going to be kind of hard to really articulate that through this camera for y'all. We're going to try, but if you could ask Kim to see if she could just find, like a 10C drip set in a bag, just to kind of show y'all how to do that. That's what we're about to do up here.
Thank you.
That's the end.
I really hope my mic was off for that whole interaction because I was cussing at the box. All right, so this is what it looks like. Bag of fluids. You guys can't give fluids as EMTs. It is in your book though to learn how to set these up. I noticed that your book has a lot of stuff where it's like, hey, prep for this for AOS. So we're just gonna go over it real quick. All right, so this is a medication. So if you're asked to set it up, we're gonna be checking the expiration date, make sure it's the right medication. Make sure it's not cloudy or anything like that. If these get expired or they get punctured, there's gonna be stuff in there. Drip sets, we have different types of drip sets. The most common one is 10 or 15. We use 60 drip sets for like medication administration, but just day-to-day patients.
And these go inside of our IV pumps.
Yeah.
So if you pull out a drip set and it's got this little chamber on it, this is specific to our IV pumps. Our normal drip sets, our 10 drops and our 60 drops do not have this little chamber on it.
Yeah.
Once you go down a little bit further, you'll see this right here. This is a port to give medication through. If we are ever in a situation where we're giving medications through this, you want to make sure you clamp above this port before we give a medication through it, so you don't shoot the medication back up this line and back into this bag. Mm-hmm. All right.
So we have our fluid bag. We have different types of fluid. This is just normal saline. We have lactated ringers. We have dextrose, which is like sugar. It's like oral glucose, but just in a bag. All right. So this is going to be our port. Some of these have 2 ports. I'm going to get where the camera can see me.
Yeah,
Some of these have 2 ports.
There's a port on the front of this one, on the front of this bag.
So the other ports usually used for adding medications.
And you'll be able to tell the difference. There's normally like a small one and a big one.
Yeah.
This isn't going to fit in the small one.
Yeah. So this, very sharp. After you take the cap off, don't go touching on this because this is going to go into their system, right? So don't be like, oh, yeah, I'm going to do it now because it's not going in patient, but don't touch on that. So once you take the cap off, be careful, be mindful. If you drop it on the ground at this point, get a new one, okay? This pops off as well. This can look different. Sometimes it's blue, but either way, there's a little pull tab on it. So I'm just going to pull the tab. And then from here, you just poke it in. Super easy, right? Don't stab your finger. It hurts.
Don't stab through the other side of the bag.
Yeah. So these normally have a little rolly clamp on it. So you can see here, you just roll it. That's how you're going to adjust whether fluid's coming out of this part or not. This must be 7. This one is kind of funky because it's the drip set. So I'm going to try not to mess. Oh, I'm just going to use the green one. So whenever you flip it upside down, this is going to start filling, hopefully.
You got to pull that little tab out.
What little tab?
Trade with me.
Yeah. Thanks.
These things are funky. So you want to give this a little squeezy squeeze and put some fluid in this drip chamber right here. You don't want to overfill it. On these, instead of the little rolly tab, they have a little tab right here that you can unscrew. And I'm going to make a mess just because that's what I do. So we're going to use this trash can. So what you want to do is get all the air out of this, right? You don't need every little bubble out of this. So people were scared at one point. They're like, if I get any air in their IV, they're going to die. They're not. It takes the equivalent of the entirety of this bag right here, or this line worth of air to actually cause any major harm. So it's okay if there's a bubble or 2. But what you want to do is you want to watch through the fluid. You want to open this up and you're going to let it drain. And you can see the fluid kind of moving through the system, right? And you're just going to sit here and let it drain until it runs out. And then once you get fluid coming out of the end right there, then we're going to close this up.
Are you gonna roll it?
Or you're going to roll it. And now it's ready to go on a patient. All right. Make sure you have a little bit of liquid in this. When you have the rolly ones, the best way to do this is to close that rolly thing, close it all the way down, stab this in, because if you don't, that rolly's open, it's just going to start pouring fluids out of it. So close that little rolly thing, squeeze this, just so you can get a little bit of feel in that, and then open the rolly thing up. Don't point this at the floor, please. Don't make a mess. Point it into the wheel well or the step or the trash can or something, and then open it up. Let it get fluid down and drain out, and then close it back, and then you can put it on the patient.
Yeah. Another thing is this part right here. Whenever you squeeze it, it puts fluid in there. I'm going to show the camera real quick. Try not to squeeze and squeeze and squeeze until you can't see where those drips are coming out. Because the way that we tell if the vein is flowing well or not is watching those drips. So if that does happen, just flip it upside down and squeeze some back into the bag and then start again. Does that make sense? Okay, cool.
It's that simple.
It's really simple. And once
It
you
is.
do it, it's easy. They're really easy to troubleshoot usually, unless you have one of these things. So, yeah.
Yep.
All right. What questions do y'all have about pharmacology? Is there any specific medications that anyone needs like extra depth on information?
Oh, go ahead.
Oh no, you go ahead.
So with the EpiPens, I will tell you one thing that I've seen many people struggle with is that little orange cap on the end has to come off. So don't run in there with your EpiPen, freaking blah, 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 and then just start shabbing. I have watched a paramedic do that because God love her. She was one of the nicest people you'll ever meet. But she freaked out and just started freaking wailing on this kid with his EpiPen, and nothing was happening, and she couldn't figure out why. So I had to take the EpiPen from her and pull the cap off and use it. So make sure you know how to use these things. A big thing that, especially if you're riding with me or you're riding with Becca, if we are there and you are giving a medication, I'm going to expect you to know why you're giving that medication, what that medication is going to do, and how much of that medication you give. If you cannot answer those questions, then I'm not going to let you give the medication. And I say that as nicely as I possibly can, because at the end of the day, right, as a paramedic, if I walk in somebody's house and they're like, oh, my chest is hurting, or, oh, I can't breathe, and I'm like, ketamine might fix them, and I slam 300 milligrams of ketamine in them, it's not going to do anything, right? So you have to know why. Don't just give them a medication because you were told in a book, oh, well, if they have chest pain, I'm supposed to give them aspirin and nitro. Well, do they have chest pain because their heart hurts, or do they have chest pain because they have asthma and they've been breathing really hard for the last 12 hours, and now the muscles in their chest are wore out and it hurts, right? So understand why you're giving these medications, understand what they're doing, and understand how much of these medications you're going to give, because that is a very, very big thing about giving these medications.
Yeah. So like I said, we're going to go into like really in depth to your medications per chapter in which they're correlated to. So like cardiac emergencies, we're going to go in deeper detail of like aspirin and nitro and that kind of stuff. So which is actually next week we're going over or this Thursday we're going over respiratory emergencies. So Saturday, whenever we come back on Saturday, we're going to be going over our medication, our skill sheets. One big thing is if you're riding along, everybody that has been working here is very familiar with those skill sheets. So don't be afraid to whip them out and be like, let's do a scenario, because that's how we're going to be testing you on at the end of class. So the sooner you get it all memorized, the better. And then what better way to start going over your medications. So I think that's all I have for y'all tonight.
Don't forget, there's going to be a change in the schedule So this coming Thursday, we will take the test over 17 and 18. 18 will not be next Tuesday. 18 will be this Thursday. So be prepared for that. Thursday, we're going over chapter 19, and you will have a test on that next Tuesday. That will be the major difference. And then next Thursday, or I'm sorry, next Tuesday, we will be going over chapter 20 in its entirety. And then Thursday, we will be going over chapter 21 in its entirety. Because right now it's got chapter 19 and then half of 20 on Tuesday, and then the other half of 20 and 21 on Thursday, or whatever it's broke down like. We're going to condense some of these down because some of these chapters are very, very large, and we don't want to hold you until 9 o'clock at night trying to do this stuff. So
Yeah.
If y'all have any issues, listen, if y'all have issues, there have been people in this class that have reached out to us to try to get help in some manner outside of class. If y'all have issues, if you ever are in doubt for anything, please let us know. If you have questions about anything that we've gone over that's just not quite sticking the way that you want it to, please let us know. We're going to try to help as much as we can. And we want to see everybody succeed. So don't hesitate to reach out. Like I said, I'm here almost every day anyway. Becca's here. We were so excited to have 4 days off, and this weekend we were supposed to be off Friday, Saturday, Sunday, and to Monday, and 3 out of the 4 days we were here. So we're here almost every day. Call us, text us. Don't call me. I'm probably not going to answer. Text me. I'll just be completely honest. Just text me and let me know what your issue is, and let's see if we can kind of resolve it or try to find a way to help anybody who needs it. Please, 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 because I want everybody to succeed here. So if y'all don't have any questions, I'm good.
Yeah,
The skill sheet test won't
if you
be till
wanna
the
do,
end
like,
of
an
May.
extra ride-along or
Yeah,
anything,
y'all
just let us know.
have time. There's
That's,
two
like,
big
final
finals
schedules.
that y'all have to worry about at the end of May. May 29th will be your final for the entirety of the class, and May 31st will be a skills final. I was explaining to some of the people earlier that part of your state EMS license, you will have to have a skills verification form that's signed off by the agency for you to be able to apply for your state license. So that will be a part of what we do. It's not a part of your national registry test anymore like it used to be, but you will have to do that just to show us that you know how to do the skills so that we can sign off on the paper so that you can get your state license. So, yep. That's it. I'm done. I'm for real done this time.
For real done.